have our immediate speaker, Dr. Rafeeque. Now hand over the session to Dr. Rafeeque. Over to you, sir.
Thank you. Thank you very much. I welcome all the delegates who are watching me. Friends, medicine is an ever-changing science. As new research and clinical experience broaden our knowledge, changes in the treatment and drug therapy are mandatory so as to provide best of the best to the mankind. This is the noble statement during the Harrison's textbook of medicine. So the topic we are dealing today is about Imeglimin, a new promising and effective weapon in the treatment of type 2 diabetes mellitus. This is my hospital from where I am delivering this talk, Pulse Hospital Nade. Friends, if you see the prevalence of diabetes, it is enlarging or it is crossing many limits, crossing very high level across the globe. You can see around 537 million cases right now throughout the globe, and they will go to around 73 million by 245. Approximately 1 in 11 adult has diabetes mellitus. You can see the rise in every continent of this world. When you talk about Southeast Asia, it has already about 90 million people suffering from this illness, and that figure will go to around 152 million by 2045. Our motherland, India, already known as the diabetic capital of the world, has, according to the recent ICMR survey, approximately 101 million cases. It's a recent survey, 2023. And if you can see, approximately 20% of the world diabetes population, they are residing in our country. So huge burden of this disease over our country. My dear friends, there are basically two challenges in the type 2 diabetes mellitus management. One is beta cell dysfunction of pancreas and another is the insulin resistance. So we will see one by one. What is this beta cell dysfunction? Friends, what happens in diabetes is that diabetes, as all we know, is a chronic state of hyperglycemia in which there is a tremendous load on the beta cells for the production of the insulin. So this heavy load makes them insensitive, makes them weaker to produce more and more insulin. They are no longer, beta cells are no longer able to sense the elevated glucose level to stimulate insulin secretion. Therefore, with diabetes, you get elevated glucose concentration. This is the reason why there is beta cell dysfunction in the diabetes. Also, this dysfunction can be a result of the cytokine-induced inflammation, obesity, insulin resistance, and overconsumption of fatty acids and saturated fat. This progressive decline of beta cell function leads to beta cell exhaustion, ultimately leading to beta cell death. You can see the pathophysiology of diabetes here. Environmental factors like obesity, smoking, alcohol, stress, junk food, and genetics. Combination of this causes beta cell stimulation, produces load over the beta cells, leading to hyperinsulinemia, the state of hyperinsulinemia, ultimately leading to obesity, insulin resistance, ultimately beta cell exhaustion, resulting into type 2 diabetes mellitus. Now we will talk about insulin resistance. Friends, we all know insulin has the quality to dispose of blood glucose in the peripheral tissue very nicely, and also it has the ability to inhibit lipolysis, to stimulate glycogen synthesis, and to inhibit hepatic glucose output. Main aim is to reduce the blood glucose level. What happens in insulin resistance is that there is diminished response to this insulin stimulation, resulting in the failure of this target tissues to adequately dispose of this elevated blood glucose, failure to inhibit lipolysis, failure to stimulate glycogen synthesis, and failure to inhibit hepatic glucose output, resulting into hyperglycemia. Traditionally, now this viewed as a compensated response, insulin secretion goes up. It is enhanced, leading to hyperinsulinemia. Now these defects like failure, like inhibition of lipolysis, stimulation of glycogen synthesis, and inhibition of hepatic glucose output failure, these defects, they are reversible if weight loss, exercise, and all proper lifestyle management if exercise or if it is undertaken with proper nutritional diet and all. However, if these mechanisms are left unopposed, then insulin resistance is the precursor event that ultimately leads to beta cell dysfunction. Here you can see the role of mitochondria. Mitochondria has been blamed in the pathophysiology of beta cell dysfunction and insulin resistance. Various factors like increased reactive oxygen species, impaired fatty acid oxidation, impaired glucose oxidation, they affect the mitochondrial functioning, ultimately leading to insulin resistance, and which has bad effects over the liver, skeletal muscle, and white adipose tissue. On the liver, what it will cause? It will cause excess production of the glucose. What it will cause on the skeletal muscle? There will be reduced absorption of the glucose in the skeletal tissues, and also there will be in the fat excess fatty tissue production, leading to hyperglycemia. If you look into the basics of the mitochondria, all know mitochondria, they are called as the power station of the cell. They produce ATP, which are necessary for our living, for our energy. They are supposed to be the key regulator for glucose-stimulated insulin secretion. And during the last few years, research has proved that mitochondrial function is closely related to various mechanisms or various defects in the diabetes, development of diabetes, like pancreatic cell dysfunction, insulin resistance, obesity, and vascular complications of diabetes. So, to summarize, genetic factors like mDNA mutations, NDNA mutations, and environmental factors like obesity, intrauterine malnutrition, environmental pollutants, they all cause mitochondrial dysfunction, ultimately leading to beta cell dysfunction in the form of impaired insulin secretion, beta cell failure, abnormal fission and autophagy of the beta cells, and insulin resistance. Finally, developing or leading to type 2 diabetes mellitus. How genetic factors and environmental factors they produce type 2 diabetes mellitus. First, if you see the mechanism of action of various oral hypoglycemic agents right now available, so if you consider bigonides, metformin, and thiazolidinediones like pioglitazone, they increase the peripheral glucose uptake in the adipose tissue and skeletal muscle, thereby reduce hyperglycemia. On top of sulfonylurea, meglitinides, and insulin, they directly act on the insulin to increase they act on the pancreas to increase the insulin secretion. Similarly, SGLT2 inhibitors like DAPA and empagliflozin, they reduce glucose reabsorption in the kidneys. Again, bigonides, metformin, thiazolidinediones, they reduce glucose production by the liver. And glucose, alpha glucosidase inhibitor, they are powerful intestinal glucose absorption inhibitors. This is how the present oral hypoglycemic agents they act to bring down the glucose level under control. But one thing is there, what is the need of the hour? What is the thing which is missing in this? So we need a molecule which should have a dual mechanism of action. Dual mechanism in the sense it should cause to produce more insulin, and it should also cause to improve the state of insulin resistance or decrease the insulin resistance. So we have a molecule from the tetrahydroplatinum compounds family. The name is Imeglimin. So Imeglimin is the molecule which is basically a Japanese molecule and developed in 2021. And Japan was, of course, the first country in the world to approve this. In our country also, 2 years back, this molecule got approval. And this molecule has numerous papers and research studies backing the efficacy of this drug. And the important thing is that this is the only oral drug which has dual mechanism of action, directly targeting both increasing insulin secretion and in response to, of course, glucose and improving the insulin resistance. So very important mechanism of action this drug has, and the different mechanism of action is the first orally available anti-diabetes candidate, simultaneously targeting all the three key organs of the diabetes: pancreas, muscles, and the liver, and also targeting the two main defects seen in these patients. Mainly the pancreas, targeting the pancreas by increasing the insulin secretion in a glucose-dependent manner, and targeting the muscles and liver by decreasing the excess production of glucose by the liver, by increasing the effectiveness of insulin or insulin sensitivity in the muscle, thereby increasing the uptaking of the glucose by the muscles. So, in this diagram, we nicely shown imeglimin acting on the pancreas, liver, and muscles, increasing the insulin secretion in response to glucose and improving the insulin sensitivity in the peripheral organs. So, my dear friends, these are the possible mechanisms how imeglimin improves the glucose homeostasis in our body. One is by increasing the insulin sensitivity, decreasing the gluconeogenesis, increasing the oxidative stress, increasing the mitochondrial function, and increasing the beta cell function also. Regarding insulin sensitivity mechanism, it increases insulin sensitivity and reduces insulin resistance. What about gluconeogenesis? It modulates genes involved in hepatic gluconeogenesis and decreases gluconeogenesis, thereby decreasing the glucose production. About beta cell function, its action on beta cell function and insulin secretion is that it protects against the beta cell death, increases beta cell mass, improves glucose-induced insulin release from islets. Mechanism of action on the mitochondrial function improves the mitochondrial function in beta cells as well as other tissues, reduces mitochondrial-induced free radical generation. And action on oxidative stress, this imeglimin molecule reduces mitochondrial induced reduces hyperglycemia dependent oxidative stress. In turn, ameliorates oxidative damage. So, my dear friends, in this slide again, same thing is shown at the molecular level. How this molecule increases NAMPT, that is a nicotinamide phosphoribosyltransferase transferase, directly increasing NAD, increasing calcium mobilization, thereby improving both beta cell function, beta cell protection, as well as enhancing liver action. Means it will increase glucose dependent insulin secretion, it will prevent beta cell death, it will increase functional beta cell mass, it will reduce excessive gluconeogenesis, it will decrease steatosis, and it will increase insulin signaling, thereby stimulating glucose uptake. The end result is reduction in the blood glucose level. When you talk about the pharmacokinetics of this drug, my dear friend, this is an oral drug administered in a BD manner. 1000 milligram BD is the dose recommended. It has got a very low protein binding, 1 to 8%, very low hepatic metabolism. Urinary excretion is unchanged. And there are no drug-to-drug interaction with sitagliptin, cimetidine, metformin like drugs. There are no cardiac complications, no cardiac side effects like QT prolongation, and there are no pharmacokinetic differences between Caucasians and Japanese subjects. And there are no food effects also. It can be taken before or after meals. Has the half-life of around 13 hours. That's why it has to be given in BD format. And this drug is not metabolized at all in the body. It is unchanged in the urine. When you talk about this patient population, my dear friends, about kidney patients, this drug, as I said, it is not metabolized, it is eliminated unchanged in the urine, therefore, dose reduction is mandatory. Those patients who have eGFR between 15 to 45, 500 milligram twice daily can be tried, and those who have severe renal insufficiency, eGFR less than 15, 500 milligram is the recommended dose. But I will tell you this as per the principal investigator of this molecule or trial, they have not recommended this drug in those patients who have moderate to severe renal dysfunction, because there are no studies conducted in those patients who have eGFR less than 45. So you have to be careful in giving this drug to those patients having moderate to severe renal insufficiency. But in mild renal insufficiency, yes, you can give. About hepatic dysfunction, yes, mild to moderate dysfunction, it has green signal, but in severe hepatic dysfunction, no clinical research has been done till today. And in pregnancy, definitely not to be given, contraindicated we can say. And for lactation, you have to consider continuing or discontinuing breastfeeding, taking into account therapeutic benefit versus benefit of breastfeeding. And transport milk has been observed in animal experiments. So you have to be careful while giving in lactating mothers. What does the data says? What does the clinical trial experience say about this molecule? When in this study, you can see the two main defects of type 2 diabetes mellitus, insulin secretion and insulin sensitivity. They have been shown to improve with this molecule. It was a 18-week trial. You can see increase in insulin secretion, red bar in those patients who have received Imeglimin, and gray bar those who were on placebo. So rise in both insulin secretion as well as improvement of insulin action was also noted. In this study, they have shown the dose-wise Imeglimin dose-wise reduction in the HbA1c level. Here you can see those patients who have received 500 milligram Imeglimin, they have got the milder reduction in the HbA1c level to the tune of 0.52. Those who have received 1000 milligram HbA1c reduction up to 0.94, and with 1500 milligram of this drug Imeglimin, 1% of HbA1c reduction was seen. You can see this in this graph nicely. Gray line represents placebo. Light pink with 500 milligram, you can see milder reduction in HbA1c. Light gray with 1000, red line with 1000 milligram, and red line with 1500 milligram Imeglimin. Significant reduction. So higher dose, better the reduction in the HbA1c was seen. Same thing, HbA1c with 500 milligram, 0.52 reduction was seen. With 1000 milligram, 0.94. With 1500, 1% was shown. See, fasting plasma glucose was reduced to up to 8.6 milligrams per cent with 500, 24.6 with 1000 milligram, and with 1500, 24.6. A significant reduction with higher dosages. About glycated albumin, also better reduction with 1500 milligram. Fasting insulin level also improved with 1500 milligram. So as you increase the dose, better is the response you got in the reduction of these glycemic parameters. In this study, they have studied the short-term effects and safety of Imeglimin and in terms of glycemic control as assessed by intermittently scanned CGM system, continuous glucose monitoring system. So study design was like this. It was a retrospective observational study of 32 patients who were administered this drug in addition to existing already the treatment they were taking. And it was designed to evaluate glycemic profiles. And patients were monitored for more than 4 weeks. So what were the results? Before Imeglimin, mean glucose was 161, after Imeglimin 141, so significant reduction. Similarly, all the parameters on the continuous glucose monitoring system, like coefficient of variation, mean of daily difference, time in range, time above range, time below range, all they improved or they have favorable response with after using Imeglimin. You can see in this slide better control mean glucose level evaluated by ICGM before and after Imeglimin. You can see uh, clearly, Imeglimin has shifted daily glucose profile into an appropriate range in Japanese type 2 patients, type 2 diabetic patients, indicating a short-term improvement in glycemic control. This was the landmark trial of Imeglimin for efficacy and safety. It was a double-blind placebo-controlled monotherapy trial in which 1,000 milligram of Imeglimin was orally administered BD versus placebo for 24 weeks in 213 Japanese patients. And significant HbA1c reduction was demonstrated, and results were consistent with the phase 2B results observed in Japan. Here you can see it was a double-blind placebo, double-blind treatment period, 24 weeks. One group received 1,000 milligram Imeglimin and another group received placebo. So this trial has observed to meet its primary endpoint with a statistically significant HbA1c corrected mean range from baseline of 0.87 as well as its main secondary endpoint in the form of fasting plasma glucose reduction. Safety and tolerability were good, similar to placebo only. This is the times to trial. Again, in this trial, this was a long, big trial conducted over 52 weeks over 714 patients suffering from Japanese patients suffering from type 2 diabetes mellitus. 1,000 milligram of Imeglimin was orally administered BD in combination with whatever existing anti-diabetic drugs they were taking. So this Imeglimin was observed to show HbA1c decrease from baseline range 0.56 to 0.92 with Imeglimin as an add-on to several existing oral anti-hyperglycemic agents. You can see when added on to other agents as monotherapy, you can see significant reduction in the HbA1c DPP4 up to the tune of 0.92. With sulfonylurea, when added to sulfonylurea, reduction up to 0.56. When added to glinides, 0.7. With biguanides, 0.67. Thiazolidinediones, 0.88. Alpha glucosidase inhibitor, 0.85. SGLT2, 0.57. GLP1, 0.12. And monotherapy, 0.46. So when Imeglimin was added in this study with DPP4, it has shown a significant reduction in HbA1c. So this drug was observed to demonstrate robust efficacy benefits in combination with DPP4 inhibitors. This times 3 trial, it was a combination of both double-blind as well as open-label extension period of the first double-blind phase. Initial phase was the double-blind phase consisting of 16 weeks in which efficacy and safety of Imeglimin versus placebo was studied in 215 patients when added to already taking insulin therapy in Japanese patients in the first 16 weeks. In the 36-week open label extension period of this trial, only 200 out of 215 patients, 208 could continue, and for the rest of the period up to 52 weeks, they continued with Imeglimin and insulin. So this was the study. This study 16-week double-blind placebo-controlled trial, randomized trial with a 36 weeks open label extension period to evaluate efficacy and safety of Imeglimin in combination with insulin in diabetic patients, Japanese, and inadequately they had glycemic control. So totally they have screened 334 patients, out of which screen failures were 119. 215 patients entered into the double-blind phase. 108 received Imeglimin 1,000 milligram and 107 received placebo. After the 16 weeks, the rest of the patients means 208 patients they entered the open label phase. 107 and 101 two groups all received insulin. So you can see significant reduction in the Imeglimin group. Here you can see time course of lactate hemoglobin over the 52-week study period according to treatment groups. The red line represents those patients or those group of patients who received Imeglimin from the first week up to the 52 weeks, a significant reduction. And in the group which received placebo for the first 16 weeks and rest of the period they received imeglimin, in this the reduction in HbA1c was slightly lesser. So the open label extension period showed a sustained mean HbA1c decrease from baseline of 0.64 in patients receiving imeglimin for a total of 52 days, whereas only 0.54% reduction in patients receiving imeglimin and insulin for the last 36 weeks. When this drug was added to the patients who has diabetes uncontrolled with metformin, what was the result? So in this study, they have studied, it was a 12-week study, and this assessed the efficacy of imeglimin when added uncontrolled patients having receiving metformin alone. So it was a trial consisting of 156 patients randomized 1:1 to receive imeglimin 1,500 milligram BD or placebo added to a stable dose of metformin. All were receiving metformin between 1.5 to 2 grams. Change in A1C from baseline was the primary efficacy outcome, and secondary outcome included fasting plasma glucose and pro-insulin ratio. Then you can see the group which has received metformin plus imeglimin has better reduction in the A1C as compared to the group which has metformin plus placebo. So A1C decreased from baseline to be 12 by 0.65% with imeglimin group and only 0.21 with metformin placebo group. Proving its efficacy when added to metformin. The same thing, improvement in the glycemic control after adding imeglimin to metformin. Similarly, what they have done instead of those patients, those who had uncontrolled with sitagliptin, instead of metformin, they were on sitagliptin, blood sugars were uncontrolled. In those patients, imeglimin was tried as an add-on therapy. This was also a 12-week study assessing the efficacy and tolerability of imeglimin as an add-on therapy, as I said, over sitagliptin in patients with type 2 diabetes inadequately controlled. You can see again better reduction with this sitagliptin group as compared to this placebo. So here you can see a better reduction with the sitagliptin imeglimin as compared to placebo and sitagliptin. Conclusion was imeglimin demonstrated incremental efficacy benefits as add-on therapy to sitagliptin with comparable tolerability to placebo, highlighting the potential for imeglimin to complement other OHs. So my dear friends, this drug can be combined. It has got the possibility of combination with metformin, vildagliptin, glyphosate, preferably. But it can be combined with other molecules also like glimepiride, thiazolidine, other gliptins. Also the risk of slight hypoglycemia or other side effects. This thing has to be taken into consideration. But with metformin and vildagliptin, sitagliptin, it can be easily combined. And what were the adverse side effects noted with this drug? So main, as such, there were no significant side effects noted. Only 1.3 to 1.4% of the cases they had hypoglycemia, symptomatic hypoglycemia, less than blood glucose of 70, and few patients, 6.7% of the group of the patient, those already were on sulfonylurea or other insulin secretagogue. When they were combined with this imeglimin, they had significantly more hypoglycemia up to the tune of 6.7%. Other side effects were also negligible, like cystitis, loss of appetite, GI upset, vomiting, abdominal discomfort, dyspepsia, increase in the lactate level, and some weight loss to only less than 1% of the patient. Mind here, there is weight loss, not a weight gain. So this molecule is a weight neutral molecule. Common adverse effects we all know with oral antibiotic drugs, metformin has the potential to cause GI upset tremendously to the tune of 53% in one study. Diarrhea has been recorded and nausea vomiting up to 25.5%. Sulfonylurea, big risk of hypoglycemia, particularly in elderly. SGLT2, we all know UTI and genital infections. DPP4, less common nasopharyngitis, diarrhea, and pyridoxines, of course, fractures, osteoporosis, and weight gain is a very big issue. That's why it cannot be given in cardiac failure or pulmonary artery disease patients. My dear friends, you can see metformin, it has got effect only over the insulin sensitivity, zero effect over the beta cell stimulation. Sulfonylurea, zero effect over the insulin sensitivity, significant effect over the beta cell stimulation. DPP4, GLP1, same, just like sulfonylurea. SGLT2, no effect over the insulin sensitivity and beta cell stimulation. It has got effect over the kidney in causing the reduction in the reabsorption of the glucose. Imeglimin, this our wonder molecule has got both actions over insulin sensitivity, action over both insulin sensitivity as well as beta cell stimulation. This is the unique molecule which has this action on these two mechanisms. Pioglitazone only over the insulin sensitive. Similarly, as I said, imeglimin is the molecule which covers all these two mechanisms, control over all these two big mechanisms involved in the diabetes management. Very big issue with the metformin, despite affecting exact cause, 20% of the people who receive metformin, exact cause of intolerance is not understood properly. Intolerance is mainly with metformin seen in the form of nausea, abdominal bloating, abdominal pain. We in our country face a big issue of insulin resistance up to the tune of 11.2%, as against 3% Mexicans and 1.6% Japanese. That's why metformin we use to improve insulin resistance. So this is the problem with the metformin. That's why in this slide, the insulin resistance they have mentioned with the metformin drug. About the efficacy of various drugs, you can see reduction in the A1C with 1.4 up to 1.4 with metformin, with pioglitazone 0.3, between 0.8, sitagliptin 0.5, dapagliflozin 0.9, acarbose 0.45, limpride 1, and semaglutide 1.2. So greatest reduction is noted with semaglutide, that is a GLP-1 analog, and metformin, followed by dapagliflozin. This study they are showing they are showing, but this because this limpride is also effective. It's a big complicated slide, but same UNSC reduction of all the drugs is shown here. Metformin 1 around 1, linagliptin 0.59, vildagliptin 0.6, exenatide 0.86, liraglutide 0.8. With this reduction, it's semaglutide 1.77, canagliflozin 0.8, dapa 0.73, impa 0.77, limpride 0.97. So, in this chart, they have summarized HbA1c reduction potential of the various oral antidiabetic drugs. Pioglitazone 13 mg 0.85, and rosiglitazone now it is not used 0.91. Commonly used drug, our gold standard we consider metformin. It is filled with a lot of side effects, like up to the tune of 153.2% diarrhea, 25.5% nausea, flatulence 12%, asthenia 9.2%, abdominal discomfort 6.4%. So with pioglitazone, there is a big issue of fractures, which was seen in the females in this study. They have not seen the fracture in males, and with in some patients they are for upper respiratory infection, headache, sinusitis also. So female fracture osteoporosis is common with pioglitazone. About dapagliflozin, you know very well, female genital mycotic infections are very common, followed by UTI, increased urination, male genetic mycotic infections as well, and discomfort with urination. You can see the percentage wise side effects with 5 mg fascia and 10 mg fascia. Sitagliptin side effects with monotherapy, glossopharyngitis is seen 5.2%, against placebo. When combined with pioglitazone, pharyngitis with headache 11 and 9 respectively. When combined with limpride and plus minus metformin, hypoglycemia came into picture 27%, nasopharyngitis and headache. So these are the side effects. Some noted with sitagliptin. So my dear friends, what should be the place of imeglimin in therapy? So I feel it has got the definite place in the management of diabetes. It can be used as a first-line agent, or it can be used in combination with other drugs. So definitely this drug has got a role to play in future, increasing tremendous burden of diabetes in our country. First line you can use in combination as well. Looking at the data, can we start imeglimin in the treatment of new patients? Definitely, data is favorable. Still, not many studies, Indian studies are needed, but the Japanese studies they have shown to be very encouraging results with this molecule. So this can be a good moment towards the treatment in the diabetes management. What will this dual mechanism of action be an advantage for imeglimin or otherwise? Definitely, this is the only drug which has got dual mechanism of action, increasing the insulin secretion as well as enhancing the solving the problem of insulin resistance. Based on HbA1c reduction data of monotherapy and combination therapy, what would be your preference? So it can be given in monotherapy and also it can be given in combination therapy. But I personally feel in combination therapy it will do a great job. With which other oral drugs can we prescribe imeglimin? So better will be better combine it with sitagliptin, DPP4 studies also there. has shown greater reduction in HbA1c, DPP4, also with bivonate metformin. You can use it with glyphosate and sulfonylureas like limiprid, but you have to be careful when combining with limiprid as the chances of hypoglycemia will go up. So this can be nicely combined with metformin and sitagliptin. What should be the probable fixed dose? I think 1000 milligram Imeglimin can be very well combined with 500 to 1000 milligram of metformin in VD format, or 1000 milligram of Imeglimin can be combined with 50 or 100 milligram of sitagliptin in VD format. What would be the ideal patient profile in which this drug could be used in mono or combination therapy? So, my dear friend, those patients who have got control diabetes with the present medications, this drug can be added as a stepping up. Second, those patients who have some contraindications to the drug because of the renal insufficiency or older age, or few patients in whom some side effects are there like obesity, weight gain, GI upset, or some other issues. In those patients also, this molecule can be prescribed. Also, fasting hyperglycemia is also one indication. Fasting hyperglycemia where this molecule can be very well combined. What would be the cost? Now, very important, keeping in mind our Indian scenario. So, I feel somewhere between 7 to 8 rupees should be the cost of around 1000 milligram of Imeglimin. So, because the drug has to be taken in a BT format, so between 700 to 8-9 rupees shall be the okay cost for 1000 milligram of Imeglimin. Thank you very much for patient listening. Thank you very much.